certainly we're good with that. So I'm going to introduce the next two and our last two speakers for the day, Noah Wick and Dr. Scott Schaff. So Noah is the National Director of Litigation Consulting at Trial Exhibits. He has over 13 years of trial experience focused primarily on medical malpractice defense litigation. He's consulted in over 2,500 litigation matters nationwide. It's probably most interesting, including the current ongoing state of Oklahoma versus Johnson & Johnson. So I'm guessing he can't tell us that much, but maybe a little. He advises trial teams on theme development, visual strategy, impression management through creative demonstrations, medical illustrations, animations, and trial support. You'll notice this in his slides. I want him to do all my slide sets, but I probably can't pay him to do that. So Dr. Scott Schaff is an orthopedic surgeon at the Everett Clinic. He's been with the Everett Clinic since 2002, graduated from the Chicago College of Osteopathic Medicine in 1992, did his residency at the same school in 1987. Dr. Schaff is speaking with us today as a chair of the Department of Orthopedics. He helped to develop a comprehensive pain management protocol and treatment for perioperative pain management. He's presented this work at JPIN and the American Osteopathic Academy of Orthopedics, and that protocol is currently being used throughout the surgical departments at the Everett Clinic, which, believe it or not, orthopedists might have been some of the biggest offenders of some of those rules. I don't know, you might have to tell us that. So we're going to talk today about opioids and the use and kind of what's happening in our legal environment. And this is the practical piece, how you might, if you are a risk manager, go back to your organizations and put the right protocols in place based on Washington state law. I want to thank our sponsor for our afternoon break, which is Beta Healthcare Group, and Johnson Grafficky, Williams & Wick for this last presentation.
Thanks. So if she didn't, I don't think she mentioned this, but Scott has recently proposed to Carrie, and they are now engaged as of this last August. So congratulations.
She was dumb enough to say yes.
He's actually probably also, as I made a comment, bordering the line of sexual harassment, that he's probably one of the best well-dressed doctors that I've seen. And most attorneys can probably agree as well. Let's get.
Terry told me I had to get a new suit at some point, otherwise I look like a slob. And since there's attorneys in the room, I had to look like an attorney or close. This is as close as I get.
So we'll get started here. There's a whole lot of stuff to talk about this. I mean, we've got 165 slides that we're going to run through. That's why we're splitting it in half. There also is a good reason to start drinking halfway in between, because the first part's a little bit depressing, but we do have a lot of fun things to learn and go through. I have a bunch of videos as well, so we're going to start off with that.
I tried Oxy at a couple of parties. I thought I had it under control. I didn't know it'd be this addictive. I didn't know how far I'd go to get more.
Opioid dependence can happen after just 5 days. Know the truth, spread the truth.
I got some Oxy after I hurt my neck. First I took them to feel better. Then I just kept taking them. I didn't know they'd be this addictive. I didn't know how far I'd go to get more.
Opioid dependence can happen after just 5 days.
This is
Know the
true.
truth, spread the truth.
So, chronic pain affects nearly 100 million Americans and costs the nation up to $630 billion a year. Untreated pain causes suffering, disability, depression, and so forth, and hence the appropriate treatment plan is to have good medical care. Got a couple other videos that I want to show that I've come across while working on this litigation, and some that we've worked putting together that will help give a little bit more background on how the opioid overdose and deaths.
We didn't see these drugs for what they truly are.
What's different is our experience of what happened with OxyContin, and I don't understand how we could not see this as a promised repeat performance.
20,000 overdose deaths are attributed to prescription drug abuse, OxyContin in particular.
The manner of death is accident resulting from the abuse of prescription medications.
This crisis has gotten so large and pervasive that it's simply beyond the scope of any one of our agencies to make a meaningful impact.
The opioid overdose crisis has led to a number of other problems, including a drop in life expectancy for the first time since the AIDS epidemic in 1993.
The data reporting is so bad that our death rates are probably twice what we think they are.
So how do opioids work? Basically, you end up having pain impulses that travel from the source of the pain through the nerves and into this, in the spinal cord to the pain centers of the brain where they are perceived. When you take opioids, you're replacing the natural endorphins, and over time the body produces fewer and fewer endorphins, leading to a dependence on the medication. So this is just some graphics that I've created for this. This is an animation that shows the physical brain damage of opioids. Initially, they create like a sense of pleasure, relaxation, and content. And anyone who's tried an opioid before, it has a great feeling. There's kind of a mix between acetaminophen and ibuprofen that studies have shown that the pain difference in the pain scale is about 1, but people prefer opioids because it gives them that endorphin rush. So after 1 month, MRI imaging can confirm a decrease in gray matter. So what a person feels much more, they feel much more than just the physical pain too. It's also emotional and psychological. For example, they might not only just be addicted to the physical things, they might be addicted to the routine of heroin, addicted to the sting of the needle, addicted to the relationship that they have with the dealer. Once the opioids disengage from the receptors, and the pain transmission increases. So the feeling of the withdrawal awakens in the part of the brain that actually makes them feel like they're gonna die. It's a huge endorphin rush that they end up getting. It wakes up with a vengeance. And if you've been using these chronically for 6 months to more than a year, it can almost take as long as 6 months to a year to stop the withdrawal symptoms from you feeling it. A lot of times people, one of my perceptions that I always had is like, why can't you just stop taking these opioids? Why don't you just, like smoking, why don't you just stop? It truly is an addiction. And because they feel like they're going to die, they end up getting their dose or they shoot up, and all it's doing for them is making them actually feel normal, so they can just live 1 more day. It's not that they're getting it to get high, they're always searching to get that high again, but that's never usually the case. They're just trying to live day to day at this point. When they go off of it though, is they end up having such bad withdrawal symptoms that sometimes, and why we see a lot of these overdose deaths besides fentanyl and some other things that are added to it, is they end up going back to the same dose that they were taking. And that's what ends up causing it. I'm gonna read so this is, I messed around with this. So this is a text message from on November 10th, 2017. And it's from a local person who overdosed. And says, I've decided, just so you can understand the feeling of what someone is going through. I have finally decided to completely stop all drug use because of 2 things. Number 1, because my health is steadily declining, and I don't think it can decline much more without killing me. I really doubt I would have more than a year left in my life if I kept doing what I'm doing. It's been up and down for the last 12 years since I left the military and hurt myself. My drug habit changed or ceased at times, where I didn't use for a year, mostly because I didn't have the resources or the people to get it from. Unfortunately, it wasn't by choice. I tried a methadone program, and it worked well, but all it did was add another drug to my system. The crowd of people I've been surrounding myself don't even know me for me. I'm mentally and physically exhausted, pretending things are good when truthfully, everything is falling apart. I have missed so much life it's unbearable to even think of. I have destroyed so many people I can't even count, all for the same reason, just to feel normal one more day. Everyone acts like everything is okay, so I wonder if they really know what's going on, or do they care? Or maybe they just gave up when I started struggling. I don't know. I don't blame anybody for the choices I've made. I was the one that made them. I cannot do it alone. Believe me, I've tried. It's not something you can just walk away from. I need my whole family to beat it, and I feel like rehab may be my turning point after it's my last shot. Afterwards, I must live my life completely different. This is where I need your help, as anything I choose to do doesn't work. I need to start all over and listen to somebody else, not myself. This is not easy for me to write, since I don't want anyone thinking that I have any kind of weakness, but I think you at least deserve the right to fully understand where I am at, and hopefully, God willing, I am in a different place by Christmas. So that was on November 17th. For those who know, that was my brother. Those who know my dad and me. So this was actually from the Seahawks game, which we did annually. And that was the text message that I received from my brother while knowing this. And I wish I would have known a lot of the information that I know now than what I knew then, because I figured that maybe I might be able to help. But at the same time, the struggle that they're going through, it's such a powerful thing that, you know, family members cannot blame themselves for what ends up happening. It's just really tough. But I wanted to share that as a personal note so people understand where I'm coming from, that I've spent a lot of time working on this, which is also why I'm part of the big opioid case right now, just trying to find a cure, get back to the States, and bring us to some type of normalcy. Moving on, there's been over 400,000 opioid deaths just as of up to 2017. Physicians relied on, and a lot of this has to do with the litigation now, is that they relied on the information that was at them at the time and what they were being told from these pharmaceutical companies, saying that there was a low potential for abuse. Here is Dr. Kalani, who I've been working with and is one of the top experts for the current trial, speaking about what they were being told.
When Purdue Pharma launched OxyContin, it was interested in a blockbuster drug. Some patients may be afraid of taking opioids because they're perceived as too strong or addictive. But that is far from actual fact. They launched a brilliant campaign that reframed all of these very good reasons for being cautious with opioids as barriers to compassionate pain care. The Joint Commission sets the rules for hospitals in the United States that they have to follow, and the Joint Commission was told that we're undertreating pain, and then agreed to create new rules so that every patient who comes to a hospital would be asked about their pain. The opioid crisis has really been caused by the medical community writing too many opioid prescriptions, and we realized that opioids were being overprescribed because our colleagues had been badly misinformed. And you're starting to see policymakers ask why every grandma's got painkillers in her medicine chest. You're starting to finally see a recognition that it's an addiction epidemic.
Then one more video regarding how physicians were misled.
Patients have real pain, and by that typically means pain related to some lesion in the body that you could palpate or see on an x-ray. That if they have real pain of that type, then they could take a potentially abusable drug, and the risk of abuse and addiction is minimal to them. That's completely incorrect.
If patients have legitimate pain, we were taught that they don't become addicted to these medicines, and that instead of allowing people to suffer needlessly, we should be much more liberal in our prescribing of opioids.
I gave so many lectures to primary care audiences in which the Porter and Chick article was just one piece of data that I would then cite, and I would cite 6, 7, maybe 10 different avenues of thought or avenues of evidence, none of which represented real evidence. And yet what I was trying to do was to create a narrative so that the primary care audience would look at this information in toto and feel more comfortable about opioids in a way they hadn't before. In essence, this was education to destigmatize, and because the primary goal was to destigmatize, we often left evidence behind.
The inappropriate promotion of drugs contributed significantly to this epidemic. But this how? Tell me how. Because drug companies took a small piece, a sliver of science, and widely promoted it as not being addictive. That was false.
Clearly, if I had an inkling of what I know now then, I wouldn't have spoken in the way that I spoke. It was clearly the wrong thing to do. And to the extent that some of the adverse outcomes now are as bad as they have become in terms of endemic occurrences of addiction and unintentional overdose deaths, it's quite scary to think about how the growth in that prescribing driven by people like me led in part to that occurring.
So I out of all the different videos I've seen, I thought those were really eye-opening. So those are two that I really wanted to share. You know, a lot of the issues that are later going to come on, and then we're starting to see more, is that, you know, they reward the doctors for prescribing it, and for them it was like a win-win situation. You know, right now, I believe you mentioned about this.
Right, so at its peak, there was enough Vicodin, this is just Vicodin, prescribed so that every man, woman, and child in the United States could take one pill every 4 hours for 3 weeks. So that not only goes to the quantity that was prescribed, but also the number of people. One quick tag on the Purdue thing, I remember when Purdue came to my clinic back in '99 and touted OxyContin as something for short-term pain for fracture care, being an orthopedic surgeon. And I was dubious, but I tried it on a couple of patients until I quickly decided that these folks could not get off of them quickly or did stupid things, person with a broken leg walking on it because they didn't hurt and demanding more OxyContin because if they stopped taking it, they hurt. Well, you might need to hurt a little bit on this broken leg so you don't do something stupid. So the way that they pushed it was real to the physicians. Now we had a responsibility to try to moderate that some.
Some other stats that we've got every 12 minutes someone in America dies from an opioid overdose. So by the time we're done with just our first half, 3 people would have died from an overdose in America. Showing some other stats, 2012, there is some good news to this, even though it looks horrible right now, but you know, Washington prescribing and death rate, we had 255 million prescriptions nationwide, so 81.3 per 100 people had a prescription. That has actually decreased. So now in our state it's 57.2, so just over about half of people have a prescription out of every 100 people. And the national average has actually gone down a little bit, although it's very much still way too high. Here's the rate for rate of deaths attributed to any opioid just within our state. This actually in 2016 was the first time that car accidents were now less likely and deaths were less likely to happen than opioid deaths. So that's where that finally intersected. So how did this epidemic become a crisis? We know that both the state and federal governments have begun to crack down on the pharmacists and the physicians who are overprescribing. One of the unintended consequences of making it more difficult to obtain prescription opioids was that more people were then turning to heroin. It actually studies show that about 80% of heroin users started with a prescription painkiller. Things here in Seattle that have been a little bit different is, I'm sure we've heard of the injection rooms, the safe injection sites. They have now actually started distributing fentanyl testing strips. So since people are overdosing a lot more on fentanyl, to test before they inject. There actually has also been innovative apps that have been created to monitor your breathing and irregular heart rhythms that you wear with a bracelet, and that if something happens, that the police can be called if they know that you are someone who is taking opioids. This shows primary non-heroin opioids admission rates by state, and I'm going to go through each year. We stopped at around 2016, but you can see how things develop. So that was up to 2009. After that, the numbers were so high that they stopped doing it. This might be a hard video to see, but one of the things that is going to be a whole separate litigation is neonatal abstinence syndrome. I'm sure many of you have seen something like this. A lot of these children now that Purdue released OxyContin in 95, 96, and then we saw later on a huge up spike. And so all the kids that were born with the syndrome, they've said are 10 times worse than kids that they see with ADD and autism in schools. As they're starting to grow up, they're having so much, they don't even know what to do with them because they have aggressive disorders. And there's just so much more research to be had. I imagine that this is going to be its own separate litigation thereafter. Hopefully not, against both the doctors that were prescribing the mother any opioids, but some more information about that shows that every 15 minutes a baby is born suffering from opioid withdrawal. It's 5-fold since 2004. This also shows the opioid use disorder on the rise. And all this is part of the package that you're able to download we sent earlier, so I know we're going to fly through some of this stuff. Here is, the drug manufacturers knew the risk. They aggressively promoted OxyContin as it was safer. They also knew about significant abuse of it in the first years and decided to conceal that information and keep pushing it. They even went so far that I've read to where they had programs promoting and pushing to sell to kids. They said, how do we get more kids to use opioids? They have real pain from growing pains. How do we convince the doctor or the doctors, the coaches, the teachers to start prescribing these to them? If we can get them hooked on early on, more money for us. Going into the White House Commission on Combating Drug Addiction and Opioid Crisis, I wanted to just show some slides from this and what it all entailed. If anyone wants to read the full document, they can. So it focused on unsubstantiated claims about the risks of addiction. We're going to go through lack of scientific evidence, pain patient advocacy, the continual medical education, aggressive promotion, pain is the vital sign, and increased supply. As we kind of mentioned earlier, there's the Porter and Jick, which is in 1980, it was a 5-sentence letter to a to a biomedical journal stating that their experience with patients with opioids was safe to use for chronic pain. Even though they never followed any of them thereafter out of the hospital setting, no one knew how much they were taking. There's just a lot of unknown, but they took this 5-sentence letter to this journal and ended up widely promoting it. So pain patient advocacy, they wanted to make pain visible. They wanted a therapeutic use of opioids, saying that therapeutic use of opioids rarely results in addiction. We found that, so one of the things that I've seen throughout this trial is that they had a series of what they call KOLs, which is key opinion leaders, They would pay certain doctors lots and lots of money, wine and dine them, and give them a lot of this false research to then go to different hospitals, go to different, medical education seminars and speak about the opioid use and how people should start, prescribing this for chronic pain. Even the Joint Commission received a sponsorship for developing the educational materials, and they were even misinformed as well. The three main uses for opioids that were ever supposed to be is for acute pain, end of life, and cancer-related pain. But, and I'm going to go into this a little bit more later on, but when Purdue found that their OxyContin was going to have such a slither of potential use, they had to find a way to convince it to sell to all people with chronic pain. And so that's pretty much where the lawsuit is right now. Everything's focused on that promotion. Again, they knew they would get a tenfold in rise in prescriptions if they could get people that had chronic pain to use it. So what was currently in the trial right now and what has drove people crazy, everyone knows Johnson & Johnson's like the baby powder, baby shampoo group. So in Australia, there is a place where they have Tasmanian alkaloids, which is where they end up getting the opium from and the raw materials in order to make OxyContin and all the other drugs that are available in the state. It's the only place that we're allowed to get an import for the United States. Noramco is the group that controls and owns the raw materials. What people didn't connect is that Noramco is a subsidiary of Johnson & Johnson. So even though Johnson & Johnson had their own painkiller, that they didn't care if it mattered, if it sold or not, because they own the raw material. So they knew that they were also told from the government that there's a limitation of how much they can bring in, but it's based on the prescriptions. So if we find a way to get the doctors to write more prescriptions, we can bring more of this in, hence increasing the supply. This also goes through and how they see how heroin and the rise of heroin is connected with the use of OxyContin. As many of you know that they came out with pain is the fifth vital sign. That's also Johnson & Johnson and Purdue that created that and pushed it. And that if you were to come into a hospital and you now have to ask every patient if they're in pain, and if they were above, like, whatever, is it 5 or 6, then they have to go find a doctor. And the VA and Joint Commission accredited this as well. All right, so we're gonna go a little bit into the lawsuits real quick. This is kind of where things started getting a little bit rocky, and the pharma companies were really pushing to scare the doctors and scare the hospitals for not or under treating pain. So now you started seeing these lawsuits where they're like, oh, a doctor was recklessly liable for not a dying man's pain and not providing him opioids. So they were pushing this, and that's kind of where we were in an era of opiophobia, which has then changed. In June this last year, the department announced 601 charges against both doctors and other healthcare people for fraud in over $2 billion, and it was the largest healthcare takedown in U.S. history, including 162 docs. A lot of, let's see, so this was something from Tampa Bay Times called drug dealers, and calling the opioid makers drug dealers and giving money to the different Florida officials. This was from just earlier this year. There was 2 doctors, one lost his license, and so he had his partner give him the prescription slip with it all signed, and he was going to McDonald's and handing these things out and meeting with people, and got caught for that. Barry Schultz, if anyone's familiar with him, he was sentenced to, I believe, like 32 years in prison, and then it was appealed, and then the judge said that's not enough and gave him 157. St. Louis jury sent a $17.6 million message. And everyone's starting to look at the doc, and this is what the pharma companies have been pushing, is like, look, we just came up with the drug. The doctors and the hospitals, they're the ones who have the power to write the scripts. And we're also seeing a lot more hospitals now suing the pharmaceutical companies, and they are also part of the MDL. State laws have been passing, or states have been passing laws to restrict the duration of the use, limit the total dosage, educate on the dangers of them, and limiting the amount that's given. We've actually seen in a recent Cleveland case that a plaintiff has attempted to use the guidelines that saying that our doctor was aware of, but were not in place at the time. National Institutes of Health. So the records and documentation are really important on a lot of these cases. Was there a face-to-face meeting? Was it a phone prescription? You know, you end up seeing a lot of things from way back when, is where you call your doctor and say, hey, it's a Sunday night, I'm in a lot of pain, you know, send a prescription in for me. You know, times have changed because of that. Going a little bit of addiction liability. This is the Tug Valley Pharmacy versus all plaintiffs. It's the opioid cases are not like the typical medical malpractice cases that I've been seeing over the last year. This was a landmark case that is the first time that physicians have been ruled liable for causing addiction. There have been a number of cases in which physicians have been sued or even prosecuted for their negligence concerning overdose. Some more stats here. There's also one in 2015, if anyone remembers.
The Roland
this
Heights
lady.
doctor has been found guilty of second-degree murder in the deaths of 3 of her patients. All 3 overdosed on painkillers she prescribed. Eyewitness News reporter Mary Hernandez is live outside the courthouse with the latest details. Mary.
Mark, jurors are headed home at this moment, their eyes red. They cried after this long ordeal. They had been deliberating for 2 weeks. As late as Wednesday, it appeared that they were stuck on a charge of second-degree murder. They said they were unable to reach a unanimous decision and instead went on to a charge of involuntary manslaughter or manslaughter. But today, they came back and it was a clean sweep, guilty on all counts.
Guilty of the crime of murder in the second degree?
For the deaths of 3 young men, the jury found former MD Lisa Singh guilty of murder in the second degree. April Rivero's son Joey was one of the victims. She says she was stunned to hear the jury's unanimity.
I just almost couldn't believe it. It was exactly what we were hoping for, but just almost unbelievable that we finally reached this moment.
To prosecute a doctor this way was an ambitious undertaking, a first in the state of California, according to the DA. Singh was not present when the 3 victims died, but had written prescriptions that were linked to the deaths. The prosecutor said it came after other patients had died, and she failed to change her prescribing practices.
Simply writing a prescription to someone, knowing that they're going to abuse it and potentially die, was the theory of second-degree murder that we had.
The prosecutor believes that the jury was swayed by the testimony of Singh's previous patients.
And we're willing to testify in front of a jury of strangers about prior addiction, the treatment they received from the defendant.
If April Rivero could speak to her son now,
What you did was perhaps not the best decision, but boy, this is a decision that basically is going to resonate throughout the country. It is going to be changing. We have a prescription drug issue in our country that's just growing daily, and this is something that can start to make a difference.
You can't hide behind a white lab coat and commit crimes. If you commit crimes and you are a doctor, you will be investigated and potentially prosecuted for those crimes.
You know, defense strategy they used that she lacked sufficient training in prescribing them. She also blamed the patients themselves and the pharmacies that had filled them and other doctors that had prescribed her them. I'm going to move over to, well, let me mention this one last thing. So the current litigation, if everyone's familiar with the MDL, which is multi-district litigation, this is where all the states, all the counties, all the cities, tribes, everyone's been suing the pharma companies and has been consolidated into one trial or a series of tracks of cases that starts in Ohio in October. the state of Oklahoma was able to actually separate themselves by saying that this wasn't a product liability case. They said it was a nuisance case. So they went with a nuisance claim, and mentioned that they're not going to mention anything federal, and that's why it's in trial today as we speak, which you can actually go on YouTube and watch it live. But I think that there's going to be a series of, now once the MDL is going to be done, hopefully within the next 2 years, you've seen a lot of different plaintiff attorneys start gathering information and wanting to sue the hospitals and physicians thereafter. The attorneys that are trying the cases right now against the pharma companies are not going to be the same ones that are going to be trying it against your doctors. Here's just a couple of websites that have come across marketing for those who have opioid addictions. Potentially as of 2015, this is how many people might be available for them to be sued. Anyone who has prescribed an opioid can be in trouble for that. But here I'm going to get off to you.
Thank you. I think Noah's done an excellent job of showing the problem, showing how it affects your organizations and your law firms and what we're going to be looking at in the future. So my involvement with this is as an orthopedic surgeon. You can see I'm one of the folks at risk here, and most of what I prescribe are narcotics. So narcotics, we don't like prescribing antibiotics because that usually means there's an infection. So when I finished residency back in the mid-90s, we pretty much had one standard prescription. It was Vicodin, 1 to 2 PO, Q4 to 6 PRN, number 30, no refills. You'd have to call in to get a refill. Even that's a bit liberal, but as soon as I moved to Washington in '99, there was Percocet, and I never prescribed Percocet as a resident. But yet the demand was here, and that has a higher MED, morphine equivalent dose. We can start seeing that folks are starting to take higher doses to get the same relief of pain. Now, from a physician standpoint, on the Sunday night, when someone had surgery 3 or 4 weeks ago, and if it's someone you're covering for, a colleague, you don't know the patient, you don't know what their pain tolerance is, there's no plug-in test for it. Say, okay, yeah, you had surgery, yeah, I can see where it hurt, yeah, maybe this is a little bit longer than we would prescribe, or a little bit more, but everyone's a bit different. There you go. No documentation, no real exam, just kind of taken as is. And C2s like Norco or Vicodin, you could actually phone in, you can't anymore. So back in 2013, the Washington state regulations started changing as far as how you treat chronic opioids. And it became very arduous, as it should. So what we have to do if we're going to prescribe opioids for more than 6 weeks is we have to get a pain score, not just the visual analog scale that you saw, which ironically, when you get the phone call from the hospital saying they're 8 out of 10, and you're supposed to do something, but yet they're snoozing, how legit is that? So we add a few things to it. Pain interference score, questionnaire, how much does it interfere with your daily activities? Opioid risk tool, these are all things that they have to fill out, you have to ask questions about. What is their current MED per day, which means in your mind you have to calculate how much milligrams per day they're taking of a drug and convert it into morphine equivalents. Get a urine drug screen if they're on it for a certain period of time. The PMP, which we're going to talk more about, was mentioned this morning, which is an excellent tool, but also a bit clunky in its original phases. Opioid contracts, have the patient sign that you're only going to get them from one provider. If you disobey these rules, don't come in for your prescribed appointments, fail urine drug screen, you're going to be cut off. And now CME requirement. The CME requirement here in Washington, they've started a few. One is a couple years ago, suicide prevention. You actually have to have, I think it's, Joel, how many hours? 6 hours? 6 hours. So for a guy like me, for Dr. Laurent, obviously he's going to see a lot of suicidal patients. I'm not going to see many in my career, but I still have to do 6 hours. There's only a 1 hour requirement for opioids, something that I prescribe all the time. And it's a relatively lax requirement, meaning that if someone who has a CME certification talks to you an hour about an opioid, it counts. So if there's any providers here, and if this were CME accredited, you would get your hour for it based on this talk. So starting last fall, they started to really ratchet down on perioperative pain as far as what the regulations are. You have to be able to document you started with a non-opioid. You have to check the database. You have to only give them a 3-day supply. If they fall and break their arm, you start with 3 days, and then they have to be reevaluated, and the time period ends on acute pain at 14 days, unless other criteria are met. And in refills, it's the same thing, evaluation, documentation. Document the change in pain level, how it affects them on a daily basis, and come up with a weaning plan. So I'm an episodic pain manager. I do surgery. I expect that people are going to hurt after surgery because surgery hurts. Because we do things with sharp objects that make risk managers uncomfortable. So again, what this graph shows where the orthopedics department at the Everett Clinic started as, these were patients that were considered chronic opioid. Okay, they met the more than 6-week criteria, a certain number of pills. So our department had 159 patients that were attributed as chronic opioid. Yet we only met the criteria 14% of the time. Any risk managers here uncomfortable? Any defense attorneys here uncomfortable with that? Should we get sued, as some of my 18,000 colleagues might? So, where did we start? Really, where does this start? We had no standard prescribing. All 7 of us did it 7 different ways. The 7 of us and 7 PAs did it 14 different ways, and no one knew. We never talked about it amongst each other. There really was no literature, and that's one thing I'm happy and sad about what we've developed at the Everett Clinic, is that we were cutting edge. We got to it before the Breed Collaborative, before articles came out in the Journal of Bone and Joint Surgeons. However, we get no credit because they all published it before I had a chance to. So you all heard it here first, we started. And pain, again, that 5th vital sign, that lady who's snoozing in the hospital with an 8 out of 10 pain, we had to do something about, or face litigation for not treating pain adequately. So we started with, and we're going to go into this a little bit later, in the second half after we get a little bit of alcohol and all you. Yes. We were able to get resources from the organization, and I thank Carrie for helping with that in our organization. And we were able to actually get a group together and start a process, and the process that we decided to undertake followed the Cotter principles on change management. So we actually walked through all the steps of it.
Happy news.
Happy news?
Yes.
We'll do some happy news. We'll give some tools, right? Didn't you used to hate that when your math teacher would say, I'm going to give you this for your toolbox? Okay, we're going to give you tools. So obviously trying to get on top of the opioid crisis is a multi-pronged approach that actually started in the state and federal level. For the Everett Clinic, it was kind of a trickle-down effect, not only from the national attention, and also state years. As Noah showed, the risks getting higher and higher in the state as the years have progressed. But the Everett Clinic started an aggressive program on chronic opioids amongst its primary care group several years ago, and had good success with it and got good recognition for it. And when I was sitting on the board of directors at the clinic, my argument was always, okay, I understand primary care tackling this because they have economy of scale, but how about those of us that write pretty much nothing but opioids? Where's our resources to get this problem solved as well? Here on the state, and Noah alluded to some of this, much more attention is taken, much more aggressive attention is taken, not only investigations by the attorney generals that could lead to criminal allegations, civil suits being reported to the National Data Bank. Also the requirement that we enroll in the PMP monitoring program and have proof that we've evaluated that. And how do we expand treatment to include access outside of our realm? So looking at orthopedics, what we really wanted to do, if we had to get outside of that episodic care, what is our fallback position? Where are the best resources to get that patient help when they're ready for it or when they need it? Identify them early. Now, Noah also alluded to diversion. So when you're writing 1 to 2 POQ, 4 to 6 PRN, and giving 30 at a shot, There was just an article out in the Journal of Bone and Joint Surgeons about 8 months ago. How many pills does the average arthroscopic surgery patient take? 7. 50% of them took 7 pills. We are prescribing 30. We're prescribing. That's 23 that are sitting in grandma's medicine cabinet where the teenage takes a look and says, oh, this would be fun at a party. Or, I don't know if anyone would be willing to admit that after they have some of their opioids, they keep them around just in case. There's logic to it, right? You fall, you hurt yourself, you can't sleep, it's miserable, you can't get in the doctor for a day or two, just in case. Well, those just in cases end up being diverted. And that diversion actually leads not only to opioid addiction on the medications themselves, but heroin. So that just compounds the problem. So developing a zero tolerance policy for diversion within your organizations, having a diversion hotline when this is discovered, PICS's oversights at the hospital to ensure that the right number of medications are being dispensed and it is adequately tracked. I see our surgical nurses on a daily basis ad nauseum in locked cabinets, counting, recounting all the narcotics to make sure they're not disappearing, because this is not necessarily a problem with patients. There are healthcare professionals that divert. And I've seen it since I was a resident. I at least know in every organization I've worked at in the last 25 years, I've at least known one person who was either fired or charged on diversion. And it wasn't me. Getting the right team together. This is a big one. One of the now state mandates is education on how to dispose of unused opioids. And when I actually contacted the state about this, they said, oh yeah, well here's a CDC article, okay, which was fine, I got the link, it was cool, but we have none of those resources here. So it's mandated that we tell patients how to do it, but yet it's not spread out enough yet. There's not enough places to take them. Track the vulnerable areas around surgery and whatnot, and reporting when it does happen. So this stuff, I mean, it has to be taken seriously on diversion. And I had this conversation with a patient last week. I took some of my coworkers, this is lovely. I took one of my coworkers, he didn't just admit to take it, he says, I bought it. I bought a pill from my coworker, he was good. I said, dude, channeling my cannabis. Dude, don't you know that that's illegal? I mean, I understand you feel the need, but even buying it just makes it that much worse, and you're telling me about it. I did document that in the medical record. And how many times do we hear from patients, so it may just kind of like, yeah, you took grandma's, I get it, it's illegal, you're not supposed to, but how much time do we just kind of let it go by? So, really what we're looking at here is process. How do we get ahead of this now? How do we start to bend that curve? And it's a multi-disciplinary approach. We have to be able to identify folks, we have to get them into the right treatment to do this, and we have to do it based on evidence. Now, as I alluded to earlier, the evidence on this is emerging. So, I think we're going to be a little bit behind, so it's going to take some novel thinking. But as the literature comes online, becomes more available, we have to be attuned to it, be ready to react. This one, I understand the premise, but there's still something that seems wrong about handing out Narcan. But when you think about Narcan, that now law enforcement's carrying it, first responders are carrying it, and they're asking people to carry it like EpiPens. In the perfect world, it shouldn't have to come to that, but that's not the reality. The reality is this is where we're at. So spreading out naloxone, Narcan, could certainly save lives if you run into that person who's addicted. And unfortunately, up in Everett, we tend to see a lot more people being more open about heroin use, including shooting up on the streets. Medication, having access to medication-assisted treatment programs like the methadone program traditionally, and there are newer ones coming out. The prescription drug monitoring program, I think, is wonderful. Like I said, it was clunky. It took a series of passwords to try to get into it. But honestly, and I'm going to allude to this again at the end, we have now, who's on Epic? Whose organizations are on Epic? Whenever I write a prescription now for an opioid or benzodiazepine, the PMP pops up automatically and I have to acknowledge it before the prescription will print. It literally takes me about 10 seconds, where it used to be minutes of going out of the room, pulling up that site, writing in the patient's name and pulling it up. It now comes up automatically, so that's where the EMR could be awfully helpful. And that's one improvement from it. So reversing this. Step one, we have to come up with strategies. We have to see where the right domains are to do this. We have to identify folks who are at risk, and we have to be able to spread that education throughout the organizations to all of our providers. We have to have clear goals with treatment. When I was in training, it was essentially stop. Well, Noah showed what happens when you just stop. People will go out and they will find it elsewhere. You think you're doing the right thing by saying, you know what, you've been on these now for 3 weeks, your treatment's done, I'm not going to give you any more. And if you don't identify that person as being in trouble, they will go and find it elsewhere. I have had patients that say, you haven't refilled it, I went and got heroin. And again, this is all training, simulation, all the things that we talked about in other topics earlier today. So step two is that screening and assessment. We have to have this information, and this again is where the PMP is invaluable. We also have to identify other risk, and this is the EMR can be helpful with this as well. When you look at other substances, how do we know the conversation we had earlier today? People aren't always going to come and admit when they're on cocaine. We have to do our best to try to identify those. We have to identify other comorbidities that make them at more risk of addiction. COPD and some other medical issues can actually change our metabolism to the point that puts you at higher risk. And considering, the average patients, like it says here, goes to see their doctor 8 out of 10 times because of pain. For me, it's pretty much 99.9 out of 100 times for pain. And then understanding what the risks are of that. And do we really do a good job, and do we have the right tools? Now, part of our pathway on perioperative opioids is this, and this is one of the screening tools that we use. Other tools are listed up above, but these are questionnaires we ask every patient that show if they're at increased risk of sedation, at increased risk of tolerance to these opioids. Now we have to put together some of the analytics to make the right decisions, understanding that those people who are at risk. And EMR can be, again, very helpful with this, not only to identify them based on other medical professionals that have that access, so again, multidisciplinary approach, but also for documentation. Because as all my attorney friends in the room know, if I didn't write it down, it didn't happen. So documentation of all this is very important. So now let's talk about treating those folks that have an opioid dependence or addiction. It has to be a multifaceted approach. It has to not only be the surgeon who may have accidentally caused this. It has to be the primary care physician. It has to be psychiatry, psychology. There's alternative medicines, and I'm not talking about our naturopath friends in that pathway, but although I'm sure there are naturopathic ways outside of cannabis, that can be very helpful. We have to be able to look at this on an individual level. Not everyone's going to have the same weaning process as someone will be able to just take one less pill a day for the next 2 weeks and be done. Some people are going to need a much different approach to it that may have a lot more disciplines involved. And that's where it has to be specific, measurable, and individual. Behavioral counseling, I believe, is a key to this. Because not only is it the physiologic changes with coming off of these opioids, but as Noah said earlier, this has become a habit. One kind of shotgun thing we learn in medical schools, most people will be over the physiologic addiction within 14 days for the most part. However, the psychological addiction takes much longer because it is a lifestyle change. Instead of your routine now, getting up, having breakfast, go to work, coming home, having dinner, whatever that might be, it is getting up, having breakfast, finding your supply, sticking yourself with the needle, going to the methadone clinic, whatever it might be, it's become your lifestyle, and giving that up and making change. I think we all can agree is pretty difficult. So that's a big piece of this, and that's where I believe that psychiatry, psychology can be very helpful. There are medications that we talked about, methadone, Suboxone, some of those other ones that can be helpful as far as diminishing the craving or the high of it, yet still treating pain when needed, but not necessarily getting the other effects of it. We talked about medication-assisted treatments. So again, this is a big number. 2.4 million people with opioid disorder, 80% did not receive treatment. Again, those folks are going to end up in trouble at some level. They're either going to find their heroin, they're going to find that life isn't worth living, they're going to rob stores to get their supplies. I mean, this is a pervasive problem when it comes to this that didn't receive treatment alone. Or how many times have we as healthcare professionals or our organizations had them come in and ask for help and we didn't identify it? And we sent them on their way inadvertently. So group therapy, again, another key piece of this on the psychological side can identify that, hey, I'm not the only one. You saw the story about Noah's brother. You know, he was searching to his family for help. People need the help. They need to feel validated. They need to feel like they're not the only ones in this struggle, and that's where they can start healing as well. So I think you see that there are a lot of steps and a lot of facets to this, and it's more than just either cutting them off their medication or even just weaning them down. Complementary medicines, Tai Chi, biofeedback was one that was big in the 80s when I was in medical school, acupuncture, all those things that can be helpful. How do we make these impact work? I think having a comprehensive program, as much as our organizations can develop, can be very important. The Ever Clinic actually just started a chronic pain center. We've kind of had our fits and starts with it because it's hard to find providers that will work in it. Someone alluded to earlier today that that would be the field to go into. And although there's a big demand for it, if you really wanted to get into that line of work, it ain't easy work. You know, these folks, they need a lot of help and they need a lot of attention. And a lot of times it's very emotionally draining to treat folks like this, but yet it's very important and key, especially in light of the situation that we're in. Again, we touched on all of these. And then turn back to Noah.
Well, so Scott, real quick before we change up. So, you know, I get a lot of questions about, okay, my son is addicted to heroin or opioids, you know, what do I do? How do I fix this? Now, I want to talk just a tad bit about Suboxone and what we've come across as far as that versus methadone. I have seen statistics that show that methadone and people, you know, trying that, going every day, every morning to get their methadone treatment, that long-term wise, they haven't really succeeded much. There's a study that shows France had a similar issue that we have today, except for the government had buprenorphine, which is part of Suboxone, available, and they had a 90% decrease within a year or two. And unfortunately, how many, what are the requirements in order to prescribe that?
Well, yeah, they're really stiff. I couldn't prescribe it. You have to have special training, you have to have special licensure.
How many doctors can prescribe opioids?
Pretty much all of us, anyone with a DEA license. And honestly, I've had my DEA license since '92, and it gets renewed every 2 years, pretty much sight unseen. Our credentials department just takes care of it.
So yeah, there's a total, I think it was 5% of all doctors are able to prescribe Suboxone as of this day, and they're limited to how many people they can actually prescribe it to.
That actually sounds high. I would think it's even less than 5%. Because I don't know, I'll be honest with you, I don't know any in Snohomish County. I couldn't name them. I know they're out there.
So there's a problem itself. I'm going to go into it. I mean, you're coming back here in a minute here, but I'm going to go into a little bit more of the legal defenses and things that I've come across. You know, we believe that the plaintiff bar has targeted this as the next high verdict, high exposure case. They say that it's going to be bigger than nursing home, asbestos, breast implant, tobacco litigation, and that there's just a lot of people in the plaintiff bar ready and stocking up to file a bunch of lawsuits. I'm sure a lot of people have already seen an increase in the last 5 years of these types of lawsuits against the doctors and the hospitals. A lot of it, again, as I mentioned earlier, it's all going to be dependent on what ends up happening with the MDL, but I would say, if everyone, is there anyone that's familiar with Reptile? I'm sure everyone is at this point. Has anyone read the book? Okay. So I feel as though the Reptile is the perfect vehicle for these types of cases, and basically it's almost as though they had a crystal ball when they created that book. There really isn't any other type of litigation that looks like someone, like a doctor, not a company, is harming society. And unlike tobacco, where people can buy cigarettes from a store, the doctors are the ones that are making the decisions to give these drugs to the patients. And therefore, I think it's the perfect tool and vehicle to use against the doctors and what they probably will end up doing. I want to talk a little bit more about the defenses of this. For those who are not familiar with the Reptile, it focuses on fear, that safety is a priority, that to eliminate all danger and protect the family and community. On the plaintiff website for the book, right now says that they've had over $8 billion in settlements and verdicts using this approach. I've worked with a med mal defense attorney named Kim Childs in Denver, and had him speak a little bit more about this.
The issue involves a very complex calculus of personal responsibility versus physician responsibility. Both sides of that equation are true, and jurors are thinking about both of those, whether explicitly or not. And finally, maybe this isn't the last thing, but it's maybe the most important thing in the courtroom. This all makes an extremely good playground for the Reptile. The problem is unique because the people who create the risk by prescribing the medications are the only ones who can control the risk. It's just like the tobacco problem, except opioids are much more dangerous and much more addictive, and the tobacco companies never took an oath to protect their customers, whereas doctors did. They took an oath to protect their patients, and they are the only ones who can do so. The physicians only have limited tools available, and those tools can only help them assess risk. They cannot help them control patients because they cannot control patients. So the defense to the Reptile is an honest discussion of responsibility and risk assessment, and an honest discussion about the patient's responsibility. In my experience, jurors are extremely willing to talk about these issues and understand these issues much more than we as lawyers think they do.
Plaintiffs will claim that the physician recklessly dispensed opioids, that they never really cared about the real treatment of patients and only did what was expedient. We've seen that they've claimed that they placed personal profit over patient care, and that they needlessly endangered society at large. I know this seems really all negative. That's why we started drinking before. So one of the things for Reptile examination is we're trying to get the doctors, when they're getting asked these very blunt, sharp questions, to answer with a pivot. So example would be like, do you think that patient safety should be a physician's #1 priority? Yes. And then explain a little bit more than just answering, because that's what a lot of the plaintiffs are going to be trying to take advantage of. Just some more examples of that is, should a doctor ever needlessly endanger a patient? Should a doctor continue to prescribe medications if it's being abused? There's usually a lot more to just that answer than, well, no, of course not, and they end up using that. Opioid cases, not business as usual, cannot be defended as a usual med mal case. It's going to need a lot of innovative, specialized defense strategies, and it will be tried on what is not to be tried, what is reasonable, but what is safe. Your traditional medical case, jurors are completely aware of the crisis right now and are going to be bringing in their own bias as to whose fault this is, and that the defendant is guilty when they walk into the courtroom. If anyone's familiar with confirmation bias, go into that. For opioid cases, we want to kind of turn that upside down. There's preconceived notions. The public is already against us, against the doctors in a lot of ways, and the hospitals for prescribing these. Not a lot of them are as angry as we are against the pharma companies for this. We're doing focus groups on these types of cases as we're seeing more and more of them. And we're seeing that opinions support the doctors, but they're not 100% responsible for the addiction. So a lot of it's still going towards the patient's responsibility, and some are, with education is also now bringing the focus of the pharma companies. But we are seeing that they're going after preconceived notions of overprescribed, them being monitored, and the responsibility. Talk about witness prep a little bit. I'm a true believer that in these cases, as well as many other medical malpractice cases, that your doctors need to be as prepared as possible and go in understanding the reptile methodology and how to pivot and get out of the box yes or no questioning on these types of cases. As I'm freezing here. Specialized deposition prep, pivoting to the defense, speaking the whole truth, consulting, meeting with them beforehand. We also need to arm the defense to dispel any patient sympathy. A lot of people know someone. Does everyone know, raise a hand, who knows someone who is currently or has struggled with opioid addiction? Okay, just about everyone. I've heard stats that by 2025, that just about every single person is going to know a family member or a close friend who has overdosed and potentially died at this rate that we're going at right now. And I guarantee you that may have been actually a very different raise of hands if I would have asked this question 5 years ago, even. It's crazy. So ways to arm the defense. Physicians serve the public by treating disease and pain. So these are some of the key themes and strategies that we get across with the jurors. That physicians have a valid medical objective in the treatment and also serves the patient's best interest. That physicians acted with care and compassion to heal the patient's ailment. And then just generally, kind of wrapping up on this part, just preparing for trial, created a timeline here to kind of explain the opioid crisis as a timeline as a whole. We first started, and I mentioned this earlier, of the opiophobia, about how the risks outweighed the rewards. And a lot of physicians were not likely to prescribe these, and that's when we started getting the big hit and the series of lawsuits against them for under-prescribing meds for pain. Then we started going to the liberalization period where it seemed like they were outweighing the risks, that the doctors were being sued for under-prescribing and people started prescribing more of this. It was often used, a lot of the marketing schemes that were used from the pharma companies were to destigmatize it with the pain management clinics and the PCPs and other types of docs. And here's where we're at today from 2000 to 2018. The standard of care is being reassessed. We have a lot more checks and balances, and I actually truly believe that sooner or later here we're going to be reapproaching, if not already, the opioid phobia and a lot of different doctors not wanting to prescribe these at all. Thanks, Scott, for talking more about that. But we're going to need to find ways to bring the jurors back. Also, we need to bring them back to what it was like 10 years ago on some of these cases, because 10 years ago, when they were prescribing these opioids to certain people, the rules were different. The standard of care was different. And it's kind of like when you end up having a case that it was filed 10, 20 years ago and somehow managed to go now. Well, the standard of care is very much different than it was today. So having them be knowledgeable about that and what they encounter today is not the same. Defending against hindsight bias, building a comprehensive defense by knowing more information, doing more focus groups and mock trials on these types of cases to find out what a typical juror is now feeling today, which might be completely different. As I'm getting text messages in my pocket from my fellow colleagues over in Oklahoma right now saying that, you know, something was just said in the courtroom, people are watching online, and now you got a bunch of Oklahomans just going crazy on the streets. So it's, things have changed each day and each year. So it's important to know as we're trying these cases, with each culture, how do the jurors feel about opioids? You know, what's their tap? Are they angry about this? Who are they to blame? And that way it helps us, you know, pick a better jury too. Again, these are new cases that we're starting to see and a lot more that will happen thereon. There's limited background research. We want to know what's resonating, what issues to address, you know, how should we arm our into defense of the jurors. One of the videos that I recently came across was the Roseanne show. It was a spinoff, and everyone knows she ended up doing something bad. But they ended up killing her off using opioids as kind of a social way. So I'm going to kind of play this for those who have not seen it.
I just got a call from a friend in the coroner's office. The autopsy found that it wasn't a heart attack. Roseanne OD'd on opioids.
Not possible. When we knew she had a problem, she was only on pain pills for 2 days after surgery, then it was just ibuprofen. It's got to be wrong.
Well, I wish it was, but they think that she must have taken the pills right before bed, and with her health issues, it was enough to stop her breathing.
Wait, what? Mom overdosed?
It doesn't make any sense. I got her knees fixed. I flushed all her pills.
Oh my God. I found these pills in Mom's closet.
You know, also society and jurors are going to be affected by, you know, the great talents that were lost to opioids, and there's been a whole slew of them. During voir dire, we need to find and check what jurors' attitudes about opioids, as we know, are largely negative. We need to know, is this attitude based on personal experience or general exposure to the media? And we must use other factors for deciding on the jurors. Tips for jury selection, juror questionnaires. Juror questionnaires following up in private, and if someone had an experience or wants something that they want to share, to bring them to the side and ask them. Social media research, we've been doing a lot more of that and doing some background checks. Millennial expectations. So, yes, so millennials have seen a cost of living that seems unaffordable. So $1 million to them may not seem like a whole lot of money, and as scary as that may seem, but it's true. There's helicopter parenting and preventive measures that have caused a greater concern and awareness of product safety. And they tend to have greater expectations of people and businesses to take the safest approach. They believe that every company should do the safest approach to it to have the best outcome. And they also expect less risk due to technology. You know, anyone who is probably in high school, you tell them, like, so wait, every hospital 10 years ago, why didn't they not have all the medical records electronic on their phone and all interconnected? But they would think that, and they probably do. And these are going to be people who are going to soon become jurors probably as well. This is a causation exhibit that I created to show just other ways to put the light on, okay, well, this person died of an overdose from opioids, but there's other contributing factors to it. We've also seen a lot of these cases involve some type of timeline that people have been using for the defense of these. And lastly, I'll say that, you know, being able to have, thoroughly be able to show all the medical records and be able to go through those quickly is definitely helpful during trial. Usually they cannot be presented on just a few key select slides. Scott?
Now, so the goal of the next section, and we'll try to be quick because we're getting towards the end of the day, is how can your organization develop a clinical pathway? So again, this worked when it came to perioperative pain, but this could work for cancer pain, this could work in your primary care setting. This sort of methodology can be approached in a lot of different ways, but I'm going to kind of walk through what we did for the orthopedics department. And as you see, orthopedic surgeons are, it looks like a lot of attention around that. So with some resource from our organization, it really was more people resources. We put everyone in the same room that were all the major stakeholders. Surgeon representatives, physician assistant, we had a clinical pharmacist, nurse, medical assistants, reception staff. We had a lean project manager to keep us on track, and we also had representation from IT. And of course, we always want to look for a win-win. We want something to be safe, compliant, balance the needs of all stakeholders, and as well as documents thoroughly. We wanted to remove any obstacles. Now, if you ever try to put a bunch of orthopedic surgeons in the room, getting them to agree what time of day it is can be difficult. So, but we did want to reach that consensus. We wanted to build these into the EMR to make it easy. Easier to do, harder to follow, and also to document. We wanted to have the tools easily that stratify the risk of the patient so we can make the right clinical decisions. One of the unintended consequences, I don't want to say so, but results or interesting results of all this was patient education. We all pretty much firmly believe that if we're going to start saying no to patients on prescribing opioids at the amount they wanted, that our Press Ganey scores were going. And actually we found out it was completely the opposite. We maintained our patient satisfaction scores because we took a lot of time to educate the patients. And now even some of them that may not be happy with the decision not to give them a refill, most of them go like, okay, that makes sense. A lot of that is timing of what's going on in the population right now with the Oklahoma case and all the other attention drawn to the opioids. We also wanted a bailout. Again, we want to specialize in orthopedics. We don't want to specialize in pain management. So when we start getting out of our own lane, what is our recourse? And that is to have a good high-risk patient fail-safe up front and be able to identify that up front. And then as part of gaining consensus, we actually simulated this. Once we came up with the pathway, we got a bunch of folks in a room in front of an EMR and simulated patient situations, walk through it and see what tweaks needed to be made, but also what gains were made. So really what we boiled down to was multimodal pain management in regional blocks. So I'm talking around the time of surgery. We're not just going to give opioids. We used to like Norco or those because not only did they have the oxycodone, but they had Tylenol in it. But now we're going to actually separate those out. We're going to come up with standards based on some broad paths. And then we're also going to come up with a tapering methodology. Again, education up front, and this happens in multiple tiers. We actually developed a handwritten, the EPIC terminology for it is called an AVS, or an after visit summary. When we were developing this, we let the staff name that dot phrase. When you put a little dot and type something in, something automatically populates for those who may not be familiar with EPIC, and we actually named this one AVS Hugs because we thought if we were giving them bad information or not happy information in a happy way, it'd be like a big hug. So we let the staff name it that. That's not a very good orthopedic name, it'd be, AVS tough guy or something. But education, but not only is it in that AVS, it's also done by me, it's done by the medical assistant, it's done by our reception staff when someone calls in for a refill. We lumped our interactions into 3 major groups, and I want to draw those out of it because we also had to get consensus from our primary care colleagues on this so that the whole organization is on the same page. So we looked at the pre-op visit. We, as a department, decided that we were not going to give opioids prior to surgery. So if someone had injured their knee and had a meniscus tear, and they were referred to us, if the primary care physician took it upon themselves to give them an opioid, they were going to continue the opioid until surgery. We were not going to start it. And we did get primary care consensus around that. With the only exceptions, again, clinical judgment, certain fractures if they see us with a broken bone yesterday, it wouldn't be fair not to give them something, but again, within guidelines. The day of surgery. So now instead of just bringing them into the operating room, doing a lovely surgery on them, sending them out with that 1 to 2 POQ, 4 to 6 PR and Vicodin, we actually are giving them some medications in pre-op holding that are non-opioid, but they can help with pain, such as gabapentin, such as Celebrex, anti-inflammatory.
Didn't Celebrex, there was a whole big deal about that causing heart disease and heart attacks?
That was
Now,
Vioxx.
That's okay? Oh.
Yeah, that was Vioxx, its cousin. They came out about the same time, and Vioxx was pulled off the market because of it, but you're on the right track. And again, this is a 1 dose. Those were in chronic COX-2 inhibitors. Celebrex actually is still on the market, but it's always been really expensive because it's not generic yet. And this is a one-time dose, at least in pre-op. Regional nerve blocks. If I'm doing a shoulder surgery, I'm going to numb you up from the neck down the arm. Anesthesia is not me, I'm having my coffee. And that will last a good 18 to 20 hours. And I tell folks that. When you give you this block, you'll have no pain for 18 to 20 hours. The downside of it is you'll have no arm for 18 to 20 hours. Feels like a log strapped to your chest. I've given this talk so many times. Patience. And then after surgery, we give them instructions, ice and elevation, splinting. Those are all pain management modalities as well as the opioids. But they're also going to go home on Tylenol around the clock, an anti-inflammatory around the clock. Again, this is my same spiel. The opioids for the really lousy moments. And they know this up front. When they call in for a refill, and we got some guardrails around that, but we have a standard way it's being approached. How many pills are you taking? At what rate? Are you taking the anti-inflammatory and the Tylenol? Are you icing and elevating? What is your pain scale? It used to be when they would call for a refill, the nursing staff would automatically just put in the last prescription, 1 to 2 POQ, 4 to 6 PRN. And if we just click OK, they're going to go out with that many, and they're not going to know to change. But if they call and they say, well, I'm taking 1 in the evening for pain. Okay, well, I get a sense that we're heading in the right direction. For one thing, I can make a good clinical judgment based on that. But I'm not going to give them 30 if they're coming and seeing me in 2 days or 2 weeks. I may give them 5 if it's in a few days. I may give them 10 if it's a couple of weeks. We tell them to continue to taper. So we are instructing them as we go, but we're also customizing their pain management to what's appropriate in that moment. Now again, here in the state, the Breed Collaborative actually came up with what we already started and stole from us, but that's okay. But they actually look at it, the one thing we never really looked at is how do we stratify surgery? Everyone will feel surgery in a different way. However, I think we all can agree that certain surgeries are probably less painful than others. So we stratified them into, hurts a bit, not too much, medium, or yeah, that really hurts. The rapid recovery ones, carpal tunnel release, simple knee arthroscopy, simple laparoscopy and general surgery, tubal ligation, the things that really are small incisions, maybe 1 or 2 stitches, not terribly invasive. The medium ones are ACL reconstruction, laminectomy, bigger incisions, more invasive surgeries, would have a higher expectation of pain, and then the really ouchers, joint replacement, and lumbar fusion. And we then give medications based on each of those lanes. Now, this is where our clinical pharmacists, and how do we decide what medicines to give? Because again, we want to try to standardize this all as much as possible. We decided on oxycodone, not OxyContin. OxyContin is a long-acting release form of oxycodone. But we decided on oxycodone because we felt it was a cleaner drug. This was the term that the pharmacists used. It can be used with Tylenol. The one thing about Vicodin or Norco is that you can run into Tylenol toxicity before you'll run into the opioid toxicity in the combination drugs. So we decided to separate them out so that we can stress Tylenol around the clock without worrying about them getting more Tylenol in their opioids. Now, it has a slightly higher morphine equivalent than hydrocodone, and slightly, and tramadol, but slightly less than Dilaudid or hydromorphone. We do have recommended alternatives for allergy or intolerances. Tramadol is actually a reasonably good one for the lower pain expectations of pain, although tramadol is the number one abused medication in Europe. Hydromorphone for higher expectation of pain, again, for those that may have less tolerance or who have intolerances, and avoid combination opioids. One thing I did mention about one of my partners, and you risk folks will love this, I had a partner who used to give a prescription for oxycodone and a prescription for Dilaudid. Go home. His rationale is not to put someone in the grave. His rationale was, well, if this doesn't work and they're still in pain, I can't readily give them something stronger. I'm going to send them home on both. However, he didn't really make it clear how much time to put between the pills, when to take one versus the other. And even I got a phone call the last weekend I was on call saying I took a pill and it didn't help. Well, knee-jerk reaction 10 years ago, then okay, here, I'll up your dose. But then I started asking, well, when did you take it? 20 minutes ago. Well, a little bit more time. Are you doing this and that? So it makes us much more, it's making us ask more questions and less knee-jerk reaction. But those combination opioids are very dangerous, even if it's well-intended. But with anything else in medicine, it's the 80-20 rule. 80% of folks will fit into one category, but you have to be able to flex and make clinical judgment based on individual situations. So, overtime, so I will hurry up. Minimal pain, round-the-clock NSAIDs, NSAIDs, Tylenol. We only limit the oxycodone to 12. Expectation 3 days or less. This goes with the collaborative. If they need a refill, they should be reevaluated because they shouldn't have that much pain. Moderate pain, you give them a week's worth, you give them a refill on one, but if they need more than one refill, it's about the time you're going to see them anyway for the post-op and they need a clinical evaluation. Higher level pain, you give them enough for a week. You can give them a refill for up to that second week, but you better have them off of them by 6 weeks. We talked about that. Now, how do we deal with folks that are already on round-the-clock pain medication? And there's a methodology to that too. Number one, we want to partner with the physician who's giving those opioids. So preferably it'd be a written plan from their pain management specialist. That's a little bit logistically hard to do outside of the organization, but we're working towards that. We do set the expectations that we will keep you on your baseline. We will give you a limited amount above your baseline for a short period of time, and then you're getting back to your pain management specialist. And again, multimodal pain medication. You can increase their current MED, best to be within the same drug if possible for a short period of time, but set the expectations and don't try to avoid giving them more than one different medication for the same reasons. But we agreed to a solid endpoint. By 6 weeks, we want them either off of it or into the right hands, and that is at the latest. So using our screening tools, if we see, or just kind of our clinical judgment, this patient is asking for a little bit more than I would expect for this phase in care, I'm going to get them moved over to someone who specializes in this sooner than later. It's better for the patient in the long run. It's easier for me in the long run. I'm not trying to manage something that I'm not an expert in. We did, again, we simulated this. We publicized it. I met with primary care on it and got consensus around it. What we found was that to follow the pathway was less clicks. And who here hasn't heard about clicks in medicine? We were actually getting less refill phone calls because we set the expectation up front, and they were not angry phone calls when we would say no, or we're going to taper. They expected it. The staff was happy because they're not getting phone calls on a daily basis for refills, us saying no, or us tapering it down without the patients expecting it. And again, we are constantly revamping this. We actually just redid our ABS hugs not too long ago. Like I said, the PMP now automatically populates into our EMR. We are open, we discuss this as a department, we discuss it with patients. We do audit, and especially in the early phases, it was all by manual. I would have to go back and count number of pills and go back to certain docs and say that here's where you are. And what we saw was a 60% reduction. You have to look up to from your orthopedics. Remember, we started at about 160, and in 7 months we were able to get our COT patients down to 62. I had a bit of vested interest in this myself because I'm a nice guy. I gave pain medication, keep my patients close. My COT patients, I had, I think, up to 30 at its worst, and I am down to 1, and that patient's perfectly compliant. And the only reason why I treat him for his chronic pain is that he doesn't trust anyone else in the world except me. Chronic opioid therapy. So, can you get a bunch of surgeons to agree with something? It can be done. Sometimes it is hand-to-hand combat, but it can be done. But the 3 takeaways. Number 1, know and automate your data. It's out there, especially on the EMR. The millennials know that much is correct, and we just need to figure out how to get access to it. Number 2, develop the pathway, get consensus around the pathway. It makes everyone's life easier. And 3, document, because if it isn't written, it didn't happen. So sorry to keep you all late. I hope this was helpful, and Noah and I are both willing to help your organizations if we can.